If you're a junior clinician, you've definitely seen this. I mean, countless times, especially during a dry winter. You know that tight, itchy, just painfully cracked skin? Your patients are asking you, "Doc, why is this happening?" And today, we're going to give you the definitive answer. Really understanding this is the absolute first step to mastering how to manage it. So today, we're going right back to first principles. We're going to build a rock-solid, evidence-based framework for managing xerosis, which is, of course, the clinical term for dry skin, and mild atopic dermatitis. And look, this isn't just theory for your exams. This is practical, high-yield knowledge that's going to help you every single day on the wards. So let's get started. Our path forward is pretty straightforward. We'll start with the skin's basic structure, then we'll break down our tools, the different kinds of moisturizers. After that, we'll cover the core soak and seal strategy, tackle that real-world problem of patient compliance, and finally, we'll know exactly when it's time to escalate care. Okay, let's start with the absolute foundation, the pathophysiology. We're going to call it the skin's brick wall. You know, if you don't understand why the barrier is failing in the first place, you can't possibly hope to fix it effectively. This right here is the single most important analogy you need to grasp. Think of the outermost layer of skin, the stratum corneum, as a really well-built brick wall. The bricks themselves? Well, those are your dead skin cells, the corneocytes. But what holds it all together and keeps it strong? That's the mortar. And that mortar is a crucial lipid mixture of ceramides, cholesterol, and fatty acid. And this slide really shows the stark contrast, doesn't it? On the left, you've got a healthy barrier. The mortar is intact, it's keeping water in, and it's keeping irritants out. But on the right, that's a compromised barrier, exactly what we see in dry skin or eczema. The mortar is deficient, and that leads to this porous, leaky wall. Water escapes, irritants get in, and that is the core problem we have to solve. So, with that brick wall in mind, here's a quick clinical question for you. When you prescribe an emollient, what's its primary biophysical action? And here's a hint. It's about a lot more than just adding moisture. Exactly. Emollients are essentially patching up the mortar. These are lipid-based substances that physically go in and fill those intercellular gaps between the bricks. It's a direct repair action. And by doing that, it smooths out the rough surface, makes the skin much more flexible, and way less prone to cracking. So here's the bottom line for this section. Remember this. The skin barrier is a brick wall. Dry skin conditions are basically caused by deficient mortar. And emollients, they're your primary tool because they work by directly filling those lipid gaps, restoring the integrity of that wall. All right, now that we really understand the problem, let's talk about the solution. And it's not enough to just tell a patient to use a moisturizer. We need to be precise with our tools. So let's dive into what we call the moisturizer triad. This table breaks it down perfectly. We've got 3 key classes. First up, humectants, like glycerin. Think of these as water magnets. They pull moisture into the skin. Second, emollients, which we just covered. These are the gap fillers, like ceramides. And third, we have occlusives, like petrolatum. These are the sealants. They form a physical barrier, almost like plastic wrap, to stop water from escaping. Each one has a very distinct role. And this brings us to an absolutely critical patient safety pearl. This is a common mistake, so listen up. In a dry environment, if you only use a humectant, it can actually make things worse. See, it pulls water from the deeper layers of the skin, but without an occlusive layer to trap it, that moisture just evaporates, leaving the skin even drier than before. This is a trap you can help your patients avoid. So, your key takeaways here are: know your triad and match the right tool to the job. Humectants bind, emollients fill, and occlusive seal. Simple, and never ever recommend a humectant by itself in a low humidity climate. Oh, and a crucial safety point. Always counsel your patients that paraffin-based products are flammable, especially when space heaters are common in the winter. All right, so we've got the theory, and we've got the tools. Now let's put it all together into a practical, evidence-based strategy that you can start using with your patients tomorrow. Let's just pause here for another quick question. Thinking about the current guidelines, what is the single most important, the cornerstone, first-line intervention for these conditions? If you said liberal daily moisturization, you are absolutely on the right track. And the best way to do this is with the soak and seal method. It's a very specific sequence. After a short, lukewarm bath or shower, no more than 10 minutes, you have a 3-minute window while the skin is still damp. That's key. Then you apply your products in order. First, the humectant to bind water, then the emollient to fill the gaps, and finally, the occlusive to seal it all in. Think of it like you're creating a protective sandwich for the skin. And the evidence on this is crystal clear. For that crucial gap-filling emollient step,
ceramide-dominant formulas are superior. They've been shown to improve SCARAD scores, that's a measure of eczema severity, and significantly reduce water loss. So you're not just moisturizing, you're actually replacing the exact lipids that are missing from the mortar. This is physiologic repair, and it's backed by level 1A evidence.
So the takeaway is simple. Soak and seal is your go-to first-line strategy. Use the Triad in the right order on damp skin and really try to prioritize those ceramide-rich emollients. And remember, topical steroids are for putting out fires, for flares, but aggressive daily barrier repair is the foundation that prevents those fires from starting. Steroids alone are failing strategy.
Okay, now for the real world. Because we can prescribe the most perfect, evidence-based plan, but it's completely useless if the patient won't follow it. And the number one barrier to adherence? It's almost always the cosmetic feel of the products. Just think about it from your patient's perspective for a second. We know petrolatum is the gold standard occlusive. It reduces water loss by over 99%. It's fantastic. So why do so many patients stop using it after just a few days?
Well, it's because it's greasy, it's sticky, it stains their clothes and their bed sheets. This is where clinical empathy becomes so important. The first step is to just validate their concern. Saying something just like this, "I completely understand," it opens the door to finding a solution together, rather than it feeling like a confrontation.
The solution isn't to force them to use the greasy ointment. It's to find an effective alternative that they will actually use. You can switch to a lighter, ceramide-rich cream or even a lotion, and you educate them on the trade-off. It's like choosing between heavy armor and a lightweight uniform. Both offer protection, but comfort is what drives daily use. The goal is consistent use of a good product, not sporadic use of a perfect one. So you've optimized their barrier repair, you've addressed compliance issues, but your patient is still flaring. What's the next step? This is when we need to think about escalating care. This is when we consider topical calcineurin inhibitors, or TCIs, like tacrolimus. Now, according to the AAD 2024 guidelines, the indications are very clear. You escalate to TCIs when optimized barrier repair, plus a short course of appropriate topical steroids isn't enough. They're also a fantastic first-line choice for sensitive areas like the face and neck, and they're an absolutely essential steroid-sparing tool for maintenance. We'll end with one final, very high-stakes safety question. There is one absolute contraindication for starting a TCI, which is an immunomodulator. What is it? You cannot apply it to skin with an active infection, especially a herpes infection. Doing so could lead to a catastrophic condition called eczema herpeticum. So, the final word is this. Always, always rule out infection before you prescribe.